Good morning, everybody. It is my privilege to introduce Dr. Ryan Ball. He practices functional, metabolic, and nutritional medicine in Portage, Michigan. He sees local patients as well as patients abroad. He even as far away as the UK. Dr. Ball has an exercise science degree from Michigan State University and a doctorate in chiropractic from Life University in Atlanta, Georgia. Dr. Ball has earned his diploma in anti-aging medicine through A4M and his advanced fellowship in metabolic medicine, credentialed through George Washington University's medical school. Dr. Ball is passionate in helping people to put their chronic disease into partial or full remission through actively finding the cause or causes of their problems. These passions come from personally battling with his own chronic disease successfully. Dr. Ball lives in Portage, Michigan with his wife Leanne, and they're a lovely couple. And they have a little cat named Oliver. So, without any more introduction, Dr. Ball, you are going to be talking to us about hormones. And thank you for being here with us.
Awesome. Thank you for having me. So let's see if I can get this to move along. Alrighty. So she just went over my credentials. Thank you, Martha, for that introduction. So you covered this slide for me, and that's great. I spoke for you guys before, and we talked about nutrition and just different foods and trying to take care of some of the pseudoscience that's out there as far as saying, this type of food's bad for you and this type of food's good for you. And we kind of laid out, where each food is actually really good for you or can be, and then where maybe some people could have trouble with them. This time I wanted to do hormones. Lots of people are interested in hormones. And the big thing about the hormones is that there's even more misinformation if you go on Google. And so we want to set some of that straight. With each hormone, there is a true disease. So for example, so for cortisol, if somebody has if somebody has a, super low cortisol, sometimes that could be from an autoimmune disease called Addison's. And that is something that, needs a lot of help, from a medical perspective. And then also there's these functional problems where maybe a practitioner wouldn't call it an outright disease, but the person is not feeling very well. So the person is sick. They're definitely feeling sick. But they go to the doctor and maybe the doctor says, well, you don't have a disease yet. So we're not going to do anything about it now. And so we want to talk about how hormones are made. That's huge to to hormonal health because a lot of people don't realize that. I personally divide hormones into energy hormones or sex hormones. And there are other hormones and compounds that don't really fall into those categories, like neurotransmitters. Aldosterone is kind of a hormone that affects blood pressure. It doesn't really fall into either what I call energy hormones or sex hormones, but I feel like this is a really good way to get people to understand the majority of hormones. How quality of life can be affected, what symptoms are we looking out for, and what are some common misconceptions about these hormones in general. So endocrinology, that's the study of hormones. That's just the endocrine system is just another name for the hormonal system. So anytime that somebody goes to an endocrinologist, they have a hormone problem. Ology just means the study of. So endocrinology is the study of hormones. So where do hormones start? If I ask anybody what the mitochondria does, essentially what's going to happen is they're going to say that it's to create ATP. I just want to look. It's essentially they're going to say the mitochondria is to make ATP, which is energy in the cell. That is very true. And that's what we all learned in biology class. But there's actually many functions of a mitochondria. And one of them is to make all of your hormones. So any gland that produces a hormone has the cells that make the hormone, and then in those cells are the mitochondria, and that's where the hormones get started. So LDL, that's people call it the bad cholesterol. It's really cholesterol is separate. HDL and LDL are both lipoproteins that carry cholesterol. So there is a slight difference, but LDL is low density lipoprotein. It shuttles cholesterol, and it shuttles cholesterol to the cells. So it gets to the cell membrane. So you have your cell, and it's kind of like, here's the outside of it. And once it gets to the cell membrane, there's a protein inside the cell called the star protein, and star just stands for a bunch of really long words. And the star shuttles that cholesterol to the mitochondria from the cell membrane. And so, after this presentation, if I ask you what a mitochondria does, you can definitely say ATP, but you can also say it makes all of the hormones in the body. And so all the hormone production starts with the creation of a hormone called pregnenolone. So pregnenolone, not DHEA, is the mother hormone. It's the precursor hormone to all your other hormones. Basically it starts, branching out based on the needs of the cell and what type of cell it's in. It's going to be directed to produce other hormones through just kind of coenzymes. Those are just things that get added, and that directs the course of how the hormones change. And so really, even practitioners, even people with a healthy biology background aren't aware of how, helpful the mitochondria are and necessary they are to producing hormones. And so, when we talk about taking, doing things for your mitochondria, like exercise or red light therapy or, CoQ10, these things aren't just helping with heart health and brain health and producing energy. They're also helping us to continue to produce normal amounts of hormone. Another thing to remember when we're talking about hormonal health is how much all the glands are directed by the brain. So let me see if I can wait for me to hide this. Anyway, so all glands are directed by the brain is what that says up there. So whether you're producing cortisol from the adrenals, if you're producing thyroid hormone from the thyroid, or testosterone or estrogen or whatever, it always is directed by the pituitary gland, which is in the brain, and then that is directed by the hypothalamus, which is also in the brain. So essentially the hypothalamus uses the blood that's running to it to say, okay, I have this much hormone in the body, I need more or less. Then it tells the pituitary gland to tell those other glands what to do. So there's kind of like a ladder. So the hypothalamus is the boss. It says, hey, we don't have enough thyroid hormone. Pituitary gland, tell the thyroid to produce more hormone. And the pituitary gland produces TSH to tell the thyroid that it's supposed to produce more. So that's the chain of command in the endocrinology system. The brain is the highest chain of command. So one thing is you need the brain health to be there, and then also you need mitochondrial health to be there. And so understanding that those two things are prerequisites for normal hormonal health is really important. We can try to do things to raise somebody's testosterone all day, but while their brain is not working right, or if they have poor mitochondrial health, it's going to be, very limited in its success. Those are the people who a lot of times will need to continue to raise their dose over time. So an example is thyroid stimulating hormones. So most people who have had their thyroid tested, or pretty much everyone in the United States who's had their thyroid tested, typically will get a TSH. And that is, when we're talking about TSH, the doctor is always talking about thyroid health. And what a lot of people don't understand, and a lot of times they're not explained this, is that TSH is not a hormone produced by the thyroid. It's produced by the pituitary gland. The pituitary gland produces TSH to tell the thyroid to produce more hormone. That's why when they say your TSH is super high, that you have low thyroid. So hypo means low. So you have low thyroid when TSH is really high. Some people say, how does that work? Because that's, if it's high, then is my thyroid producing lots of hormone? It's because it's not a thyroid hormone, it's a pituitary gland hormone. So pituitary gland is told by the hypothalamus that you have low hormone, so it produces a lot of TSH. Um, the TSH is causes the thyroid itself to produce more hormone, and that is why high TSH indicates low thyroid. So what are the implications for patients? Like I already said, you need brain health. So a lot of times when people get they get traumatic brain injuries, or they, any sort of head injury, sometimes their testosterone drops like crazy. There's also research, randomized control trials, where we see giving pregnenolone, which is that precursor hormone that we talked about, or even giving progesterone to men with head injuries can sometimes help their symptoms. And is that curing it? No, but it's taking care of that low hormone that was caused by the head injury. So it's kind of remediating that and making them feel better. That's why people with concussions sometimes get into hormonal trouble. Some people will have no problem with their testosterone after concussion, but some people will have huge trouble with it. And it's kind of because it's more pituitary gland than hypothalamus. The pituitary gland kind of hangs off the brain like a punching bag. And so it's very susceptible to injury. So the pituitary gland, so TSH causes the thyroid to produce thyroid hormone. Luteinizing hormone from the pituitary gland causes men to produce testosterone from their testes. So they get that trauma to the pituitary gland. Less luteinizing hormone means less testosterone. Energy hormones versus sex hormones. These are terms that I created. And really it's just for understanding purposes. It's just for teaching purposes. So most people are concerned about their sex hormones. Those are estrogen, testosterone, progesterone. And a lot of clinics and a lot of procedures and protocols are aimed at helping those directly. What most people don't realize is that as long as your brain, your mitochondria, your immune system are all right, and the energy hormones are all right, then your sex hormones come along for the ride. So it's very difficult for your sex hormones to be normal while the energy hormones are off, and those are cortisol, insulin, and thyroid hormone. So really ideal is to get those right first, then see how much better your sex hormones get, then actually address the sex hormones if you still have to. And some people do, so it's not that treating those is wrong. It's just there should be an order of operations. So the energy hormones are cortisol, insulin, and thyroid hormone. Cortisol is probably the most misunderstood hormone. If you spend any time on Dr. Google, you're going to have a huge misunderstanding of this hormone. People call it the stress hormone. It is the stress hormone. It increases with stress. But it also increases just because you woke up in the morning. So as you sleep, the less light going into your eyes, the more you produce cortisol. And then when you wake up at 7 in the morning, you have your highest cortisol of the day. And that's ideal because cortisol is your energy. And so I don't think this is in the presentation, but if somebody dips and gets kind of tired, they're wide awake 9, 10, 11, but then they kind of start getting really sleepy at their, in their chair at 1, 2, or 3. That's a dip in cortisol, and that's clearly not helpful for a full day of work. So cortisol is good. You need it in the morning for energy. Some people say that it's a pro-inflammation and pro-weight gain hormone. That's not true, and more of that in a second. And we also talk about things like the adrenal fatigue and the pregnenolone steal. Adrenal fatigue and pregnenolone steal. Adrenal fatigue refers to the fact that if you have super high cortisol for a long period of time, eventually you'll have low cortisol and it'll stay low in spite of maybe having better practices. That is a phenomenon that happens, but adrenal fatigue is a misnomer, and it causes people to treat it incorrectly because the adrenals actually don't get fatigued. They don't even store cortisol. They actually have no cortisol in them, and they produce cortisol on a need basis. Pregnenolone steal, that's a phenomenon that refers to if you have high cortisol for a long period of time, you'll get low testosterone. That is true. But they're saying that it's because the part of the adrenals that produces sex hormones is not being used as much and the cortisol is being used more. And so it steals the pregnenolone to make cortisol instead of testosterone. That's not true either, because not only do zones of the adrenals not share pregnenolone, cells don't share pregnenolone, not even mitochondria within the same cell or share pregnenolone. And so a little bit more on that later too. So the function of cortisol is to pull stores of energy out of their storage places so that the person can feel more energy. So the more sugar or energy that's in your bloodstream, the more you feel like you're energetic. And that feels good, especially in the morning when you need to get up and about. So really, cortisol is anti-obesogenic because it pulls stores of energy out of storage places. So fat is a storage place. And so you pull stores out of there with cortisol. Cortisol is naturally highest in the morning. We talked about this, so that you can have more energy throughout the day. And then it should naturally dip in the evening where melatonin would be at its highest, and then you can fall asleep. And then it goes, so they kind of are on a teeter-totter. So cortisol is high, melatonin's low in the morning. Right before you go to bed, they should flip. Now you're ready to go to sleep with high melatonin and low cortisol. So cortisol is anti-inflammatory. Most people have heard of the drugs cortisone and prednisone. Those are steroids that are anti-inflammatory, and they were designed by pharmacists after cortisol. So pharmacists and scientists and bioengineers, you know, they say these chemists and everyone, these scientists, they say, look at cortisol, it's anti-inflammatory. Let's make drugs like that because we know they work in the body. And so cortisone is more powerful than cortisol. Prednisone is a lot more powerful than cortisone. But cortisol, like prednisone and cortisone, is anti-inflammatory. When you have stress, you create inflammation and cortisol, and then they meet up at the same place and they cancel each other out. And that's a good, healthy situation. So you don't have any excess cortisol and you don't have any excess inflammation. You're at a net neutral and you meet in the middle. That's how it's supposed to work. Cortisol is also anti-weight gain. It causes you to release energy from stores. So fat is a storage spot. People with low cortisol are going to have a lot of trouble losing weight. People with, normal cortisol don't have a problem losing weight. So where does the misconception come from? The scientists aren't wrong. Bloggers on Google are wrong. So if you spend time on PubMed, which I recommend everyone do, if somebody says something about health or medicine or anything, I recommend going to PubMed and looking at the research and seeing what it is, because that's the national database of medical research, and most of the articles are free to go to. So instead of just saying, well, this blogger said this, you can take what that blogger said and go right to PubMed and see if they're right or wrong. I wouldn't go based on the first article you see, maybe see if there's multiple articles on the same thing and then use the, what has the most evidence as your choice. But it's not the scientists that are wrong about this. They are very clear on it. Cortisol is anti-inflammatory. But what happens is people think that it causes weight gain and inflammation because of cortisol resistance. So just like somebody with diabetes type 2 has insulin resistance because they signaled insulin too much, somebody who is stressed often is signaling cortisol too much, and then so they can get cortisol resistance at the receptor. Now, because cortisol is anti-inflammatory and anti-weight gain, that cortisol resistance ends up causing weight gain and causing inflammation. So it's true that if you have high stress for a really long time, eventually you'll be unable to lose weight and unable to resolve inflammation. But the cortisol isn't causing it. It's the resistance to the cortisol. You wish the cortisol would work, but it's not anymore because you did too much of it. And that can be stress on a daily basis for a long period of time. That could also be, and there's different thresholds for different people. That could also be a very high stressful event that keeps you stressed for a long period of time. And that can get you into that rut of cortisol resistance. So there are ways to fix that. But that's an example of, something that wouldn't necessarily be an outright disease. It's not Addison's disease where somebody has, too little cortisol. It's not Cushing's disease where somebody has too much cortisol. but it's irregular and the person is not feeling very good, and it is a risk factor for other problems. So high cortisol, you'll feel really stressed out. You'll be extremely anxious. You'll probably sweat easier. The disease that comes with high cortisol is Cushing's, but once again, you can have high cortisol without having that disease, and that is a problem. So the lab high for my lab is around 19. I had a patient who was at 40. People with Cushing's typically are around 50. And so 40 is kind of, it's iffy. What we did was we had her test in the evening. If a person has cortisol or Cushing's disorder, then essentially it's going to come down at night, and it's not going to come down at night. It's supposed to. So we tested that person in the evening, and lo and behold, it was down. So they didn't have Cushing's, but they were quite high. They were double the lab high. And so, 2 months of working with that person, we did the test and it was at 17. So lab high is 19, 17 is right, perfect in the morning. One sign of high cortisol is inability to fall asleep, as well as, like we talked about, feeling wired, perspiring easily. So a little bit of exertion will start to make you sweat. Stress is the main cause of cortisol. You can also get more cortisol from inflammation, and we talked about that a little bit. Chronic disease spikes cortisol because you're inflamed, but also it's insanely stressful to be chronically sick. And then blue light spikes cortisol. And so people with low cortisol, this is funny because usually blue light is looked at as terrible in all situations. Blue light spikes cortisol every time. If you have low cortisol in the morning, that might be helpful. It's always terrible at night to do blue light. So you want to limit your blue light. You want to close up to your face is worse than far away. Phone or tablet is going to be much worse than a TV. But really restricting as much as you can is ideal. And that just helps you to get to sleep better. If somebody's having trouble falling asleep, one free thing that you can do is just start limiting your blue light exposure. Or you could even look into blue light blocking glasses. And I will say that blue light blocking glasses that are clear do not block blue light. And even the test strip that they have, and you can, you put it over and you see it disappears. That's actually a super, it's actually even though it looks blue, it's technically violet. So it's kind of a scam deal. You really want a blue light blocker that is orange or red. Orange is kind of the best because you can get more color, so it's kind of more fun. But some of these red glasses are only $7. Let's see. Low cortisol is just about bad of a problem. That's one of the reasons why somebody might be able to, diet and exercise profusely and then still not lose weight. And so that's extremely frustrating for some people. That could be a low thyroid, but also it could be a low cortisol problem. And usually low cortisol is going to be from that cortisol resistance and that phenomenon of adrenal fatigue, even though the adrenals aren't getting fatigued. So the brain, when people have high cortisol for a long period of time, the brain, the hypothalamus that we talked about that's controlling everything is actually what stops the adrenals from producing more cortisol. Cortisol raises heart rate, and having a raised heart rate for a very long period of time that never goes away is extremely bad for the body. And so the brain says, I don't want to have a heart attack. So even though we're stressed all the time, adrenals, stop your job because this is the world we live in and we can't take anymore. So the adrenals aren't fatigued. They're listening to the brain. They're listening to the hypothalamus. Adrenals can't get fatigued. If you have an adrenal tumor, you'll produce large amounts of adrenal hormone nonstop, and it will never stop. If adrenals got fatigued, eventually it would stop in spite of the tumor. You can also induce adrenals to produce with a drug hormone, and once again, it never stops. And so adrenals, it's a misnomer, and it is a problematic misnomer because when we say adrenal fatigue, we give the impression that if you give adrenal cortex or do something healthy for the adrenals, that it's going to get better. And it's not, because the adrenals are healthy. They're just listening to the brain. So adrenal fatigue, so adrenal cortex, taking it as a supplement, adrenals weirdly are an animal product that has high vitamin C in it. So it's a good source of vitamin C, and vitamin C is helpful for the adrenals. But once again, that's to give somebody adrenal cortex for an adrenal problem that is resulting from the brain doesn't make any sense. Signs of low cortisol: cannot stay asleep, can't lose weight, you feel inflamed. And once again, the disease side of this would be Addison's disease. That's autoimmunity of the adrenals. FYI, most people don't know they have Addison's disease until the entire glands are about 90% gone or more. So it's extremely rare for them to catch this before they can do anything about it. And that is a disease that people are going to need some cortisone or some replacement therapy and some other stuff. But we're not talking about that. We're talking about people who have low cortisol and no disease, and that does happen all the time. And that's more of a quality of life issue than this is a disease issue. Insulin is extremely powerful. It's involved in storing energy and storage tissue. So if you have sugar in your blood, you might spike a little insulin to lower it. And the way that it lowers it is it puts it into stores. So, if you're a person who eats carbs and then gets really sleepy 15 or 20 minutes later, then that's a sign of insulin resistance. And while you're sleeping, you're essentially putting on fat. Insulin, like I said, is extremely powerful. So there's a few hormones that help you to get stores out of cells. Cortisol, we already talked about. Thyroid hormone does it to a lesser extent. Adrenaline, noradrenaline both do it. Human growth hormone does it. And glucagon does it. And you can always remember what glucagon does because glucose is gone. And so they spike glucagon, and then you get a nice higher blood sugar. So there's essentially 5 hormones that are working to keep your blood sugar high, and then only 1 hormone to work against them to bring it down. That's why insulin is super powerful. It's the 1 hormone that's doing it, but it can still overpower all those hormones together. And so it's good. You need insulin, and bodybuilders leverage insulin. They use it to bring protein to the muscles. So insulin is not such a bad guy either. But we do have a bit of a problem with it in the United States because we end up, getting to a point where we signal so much insulin that now we have to, cut carbs that would normally be healthy, and then, you would have to cut healthy carbs, take metformin and these other things. So eating carbohydrates is the main one. Protein does also cause an uptake in insulin. Eating way too many carbs eventually will cause insulin resistance. And insulin resistance and type 2 diabetes, it's a huge contributor to heart disease, which is the biggest killer. It's the most common cause of blindness, most common cause of amputation, most common cause of kidney failure. It's associated with cancer. It's so associated with Alzheimer's disease that some researchers call it Alzheimer's type 3, or diabetes type 3 rather. It's very involved in non-alcoholic fatty liver disease because the liver has to turn excess carbs into fat, and when it runs out of energy, it can't move it out of the liver anymore, so it just plants it there. And sometimes I hear people say, I take metformin and I take insulin so I can eat whatever I want. Well, that person is still, they're not doing what they need to do to prevent the other things that come after diabetes type 2, like blindness or amputation, or infection of the fat. So it's really, it's important to realize that, and it's important to not say, just because I'm taking these, I can eat cake and stuff, because those people are still sick. It might make their blood sugar look okay, but it does not make their health okay. So inability to lose weight happens all the time. Insanely tired after eating a meal with carbohydrates, and I'm talking about 15 to 20 minutes later, maybe 25. If you get tired an hour and a half later, that's not this. Crave sugar, crave several meals per day. Insulin resistance also causes sex hormone problems too. So we talked about how the energy hormones will poorly affect sex hormone health. For men, it causes them to aromatize, and aromatase causes you to turn your testosterone into estrogen. So then men get more estrogenic. Women, on the other hand, get a little bit of the opposite. PCOS, polycystic ovarian syndrome, that is when women have too high of androgens, so like testosterone. It's the most common cause of infertility in women. And PCOS is largely caused by insulin resistance, and there's plenty of research that shows that. So PCOS, more of a hormonal problem, and it's really an insulin problem, even though the estrogen and the testosterone is really off in those patients. So for those patients, instead of going after the sex hormones, probably go after insulin instead. Thyroid hormone, multiple factors pertain to thyroid, and when it gets tested, you really need to test the full thyroid panel. Doing a simple T4 and T3 and TSH is adequate if you're only going to eventually give hormone therapy. But if you want to, really give the thyroid what it needs, you're going to need to evaluate it in a multitude of different ways. There's multiple reasons that somebody could have low thyroid. So the thyroid itself could be producing less than it's supposed to, and that's usually a nutrient deficiency problem. The pituitary gland, maybe from a head trauma like we talked about, could be under signaling. So that would be called secondary hypothyroidism. Sometimes the thyroid gland is producing plenty of T4, and you'll find that T3, which is the more active one, is super low. So you're under converting. So you're supposed to be able to convert T4 to T3. Some people are having trouble with it. A lot of times that's actually a nutritional problem. And then finally, autoimmunity. So autoimmunity is damaging the thyroid, and then the thyroid is producing less hormone. I will say that most of the people in the United States have autoimmunity and it's undiagnosed if they have a thyroid problem. People who are in other certain countries where they don't have enough iodine, those people have primary problems because of iodine deficiency. So we don't have iodine problems in the United States just because of a variety of different reasons. That's good. But because of that, thyroid is still a huge problem in the United States, and most of it is autoimmune, not low iodine, in spite of what some people say. A full thyroid panel would include TSH, T4, and T3, which most people get, but most people don't get free T3, free T4, T3 uptake, reverse T3, and then the antibodies to tell if it's autoimmune or not. So lots of symptoms from low thyroid. If you have low thyroid, it's affecting everything in the body. You could theoretically have most things or most bad feelings from a thyroid. But what I see is kind of the telltales are, I'm exercising, I'm dieting all the time, and I'm not able to lose weight. That happens all the time. Headaches and brain fog and fatigue. Fatigue's a big one. Brain fog can be a big one. And I've even had people with joint pain. That seems to happen. If you have one autoimmunity, you're more likely to have others. And so sometimes that's just because they have another joint autoimmunity. So maybe they have rheumatoid and they have Hashimoto's. But sometimes people have no at least diagnosed rheumatoid and they're still having the joint pain, and it seems that it gets better as you address the thyroid. And even people with normal thyroid levels can have symptoms of non-optimal thyroid. So, most people don't get hormone replacement until their TSH is at 4.5. So remember, higher on the TSH is worse, or lower rather. But people can have non-optimal, thyroid and have symptoms from that, even as low as 3. So people can be 3 or higher, and their thyroid's already not working very well, but they're not getting treated until 4.5, if that makes sense. So just because you're within that range that we go by doesn't mean that you're healthy. Some people need more and some people need less. They say, just for clarification, the research says that quality of life is maxed out at around 1.6, 1.7. So a quality of life is is pretty much the best. And that's an average. That's not for everyone, but 1.7 is basically, ideal. 3 is much higher than that. So sex hormones, they're a great picture of how healthy overall somebody is because, all the things I listed earlier, insulin, cortisol, thyroid, immune system, brain, and mitochondria, that's a lot of aspects of health. If these are all good, the sex hormones are pretty much good. And I'm talking about estrogen, progesterone, testosterone. And that's exactly what I'm saying here. We're going to be talking about men with testosterone, women with estrogen, progesterone. Just so you know, men do have estrogen, progesterone, and they are necessary to a certain degree for men, and women do have testosterone, and that is necessary for women to have a certain amount of. But we'll, just for the sake of the time and the conversation, we'll just focus on estrogen, progesterone for women and testosterone for men. So progesterone is usually not problematic. The way a woman's cycle goes is they started off with super high, which is normal, estrogen, and then very low progesterone. Then they ovulate, and it kind of flips. So the estrogen comes down to middle, and the progesterone goes up to where estrogen was. And then as you go into your period, they both detox out. So estrogen, progesterone low, estrogen halves, progesterone goes up to where estrogen was, then they both detox out. And that's how it's supposed to go. People with abnormal cycles, they are going to find that usually, this isn't the case, and I have a couple of patients who break this rule, but usually what happens is it's the follicular phase, the high estrogen phase, that is off. And so it's supposed to be a 28-day cycle, 14 days and 14 days. The estrogen phase, the follicular phase, is off. And usually the luteal phase, which is the high progesterone phase, stays at 14 days. So if somebody's having a long cycle, usually it's the follicular phase getting longer and luteal phase is still 14 days. If they have a short cycle, usually the follicular phase is shorter, luteal phase is still 14 days. And I know not, somebody out there is going to say, well, I'm different from that. That definitely can happen, but most of the time it's going to be the original scenario that I talked about. And that's just one example of how progesterone is tough to, for it to go off. Some people use progesterone for, therapeutically, they don't even look at the levels. They just use it to address particular problems. And there's reasons to do or not do that. Seems like there's some people who have helped a lot of traumatic brain injury patients by giving them progesterone, even men, and that seems to be fine. I like testing, but I find that most people, progesterone is a good way to get somebody to feel better, not a good way to fix somebody's problem. And usually progesterone is not really that off. There's essentially, other than disease, so there's estrogen related diseases, and we're not going to talk about those. But there's essentially 2 estrogen problems. There's too much estrogen. And most of the time, those are women who are premenopausal, and they get worse around their period. So estrogen is supposed to tank during period. If there's way too much, then that's stress on the system to eliminate it all. And the more and more that happens, you don't get it all out, or you stress the system. Each time that's harder and harder to do. So that builds up, that's compounding. And then one day you wake up and you go, oh, wow, I never had, period this bad. So menstrual acne that gets worse around that time, menstrual migraines, those are classic. Menstrual migraines happens all the time. And so, speaking on progesterone, this is a too much estrogen problem, but some practitioners will give progesterone to help that ratio. And the patient will feel better. The problem with that is the estrogen is still too high. That's the cause. The cause isn't taken care of. And that person will probably be a progesterone forever patient, because if they were to come off of it, that too high of estrogen is going to cause them to have a problem again. But any symptom that worsens around the period could theoretically be high estrogen. And they, the kind of the buzz term on Google, and there's some research for it, is estrogen dominance. Now, you could also get worse around that time because of iron deficiency, and essentially the extra bleeding is making you even more deficient. But basically that's up to a practitioner to determine if it's one or the other. So too much estrogen, and from a disease perspective, that'd be like estrogen related cancers. That can certainly happen. The second estrogen problem is too low of estrogen signaling. And so that's typically hot flashes after menopause. And so before menopause, women are using an estrogen called E2. It's called estradiol, and it's very powerful. Once they go through menopause, they stop. They still produce estradiol, but it goes down to quite a low amount. And then one of the estrogens that was super low is now the main one. That's estrone. It's much weaker than estradiol. And so it feels to these women that they had a good amount of estrogen, and then they go through menopause, and now their estrogen's nothing. It's not nothing, it's just a different type, and it's much weaker. And so that's less estrogen signaling and hot flashes or more hot flashes. You don't really want to push estrogen. There's too many high estrogen related cancers to try to, I'm not a big fan of pushing estrogen. I know some people do it, especially in birth control, sometimes you do it. I'm not a big fan of pushing estrogen. Much better to just help the estrogen signal. So the estrone that you have, just have it signal. And that can be done in a couple different ways. Testosterone. So people talk about it for muscle growth and facial hair. Certainly does those things. It's extremely necessary for health though. Bone health, brain health, and heart health. And a lot of people, when you first learn the hormone system, and there's a lot more that goes into the female side of it too. The luteinizing hormones playing in there, and follicle stimulating hormones playing in there as far as signaling the estrogen and progesterone. So there's a lot of things to juggle on the female side, and only essentially one hormone on the men's side. But weirdly, women seem more hormonally resilient than men. When a man's testosterone gets low, it can be quite challenging to bring it up. That's one of the focuses of my practice. And I had a 306. That's not considered low, but I find with my research that 500 is a good level for optimal health. Certainly you could feel better on more than 500, but there's no research that says that those higher levels are actually making you live longer. But 500 would be good. And I have been able to get myself, from 306 up to 754, using what I know. And that's been, quite a good change for me. And my patients who come in for that, they typically get more than a doubled amount of either total or free or both, without replacing testosterone at all, by fixing pathways. So problems with testosterone, chronically high cortisol. We talked about that pregnenolone steal. Zones don't share pregnenolone. And some people will talk about taking pregnenolone too. My research on that is that when you take pregnenolone, it works very differently from how it does when you make it in your body. It actually causes calmness. You should take it at night. And it actually is sort of if you ever heard of GABA, it's a neurotransmitter. It's your calming neurotransmitter. Taking pregnenolone increases your production of GABA, increases GABA receptors, increases sensitivity of GABA receptors, and increases a coenzyme called glutamate decarboxylase. And what that does is it basically turns your glutamate into GABA, and actually it increases this. So it increases your turnover of glutamate to GABA. So in 5 different ways that it improves GABA in the brain when you take it as a supplement orally. When you make it in your cells, it's obviously going to cause you to produce more hormones. Some people have suggested take pregnenolone, you'll make more hormones. But what I've actually seen is that you take pregnenolone, the hormones don't change much on blood work. And maybe that's, maybe I haven't given it to enough people to see it, but the research seems to show that, taking the hormones obviously raises it. Taking DHA will raise certain hormones. Taking pregnenolone doesn't really, but it does help GABA. So, sometimes that can be a helpful thing for some people who have low GABA. Insulin resistance, we've talked about the aromatization of testosterone into estrogen. Dihydrotestosterone, this is where people, they'll commonly say, oh, I don't want my husband, to take, testosterone replacement because I don't want them to get angry or have roid rage. If somebody has high, what's called 5-alpha reductase, they're turning a lot of their testosterone into dihydrotestosterone, which is very powerful as far as building muscle, but not brain healthy, not bone healthy, and not heart healthy. So it's not very good for the person. And regular testosterone that isn't turned into DHT doesn't cause roid rage. It actually causes kind of a calm confidence in people. People who have a super, high turnover into DHT, they can even be given hormones. They can be given androgel or testosterone replacement, and they'll turn it all into DHT, and then they'll get roid rage. Same thing with the insulin resistance. So if you give somebody with insulin resistance a bunch of testosterone, sometimes they can aromatize a lot of that if they have a lot of that activity, and they get even more estrogen from it. So before anybody takes testosterone, it's ideal to make sure that they're not turning into DHT, not turning into insulin resistance, or not turning into estrogen rather, sorry. Low pituitary signaling after head trauma, that can definitely do it. We see that all the time in concussion. Low vitamin D, you need vitamin D for making testosterone. You need vitamin A, and actually supplementing vitamin A imitates taking testosterone, even without concurrent raises in testosterone, but you also need it. Zinc, you absolutely need zinc for making testosterone. Vitamin K2, not K1. K1's the clotter. K2 does not clot unless you take bottles and bottles and bottles of it. And magnesium. You need magnesium for hundreds of processes in the human body. You do need it for testosterone production as well. Too high of sex hormone binding globulin. That is, essentially a problem with the liver producing too much SHBG, and that can be helped. If somebody has low testosterone in their teens or even under 30, you might consider testicular autoimmunity. It used to be that you could test that through LabCorp or Quest. To my knowledge, LabCorp has taken away that test just because nobody was ordering it, which is sad. I don't know if Quest still has it or not. And I think a few hospitals do, but not every single one. But essentially, you don't want to miss that. You don't want to have an 18-year-old who needs hormonal replacement therapy and then just say, well, here's your hormone. Sorry that you're an 18-year-old with low testosterone, because that damage is going to continue happening. Really ideal to try to prevent soft tissue damage and give the testes a break from that autoimmunity, one way or another, whether you do that medically or naturally or both, and usually both is ideal. Low dopamine. So dopamine's your gratification neurotransmitter, to your reward cascade is what they call it. Dopamine is used for energy and a lot of other things too, but dopamine pushes testosterone. So anything that messes with dopamine, anything that you could be addicted to, that's messing with dopamine. Anything that brings you gratification or pleasure is a dopamine problem. And so some things that are extremely healthy for dopamine are long-term, daily, or consistent effort over months and maybe years, and then you hit your goal. So maybe your goal is to do 50 push-ups in a row, and then so you work for months, and you eventually get to 50 push-ups in a row or 100 push-ups in a row, and then you feel gratification after those however many months, and you go, wow, I really accomplished something. That's super healthy for the dopamine system. Or maybe you want to learn a new language, so you start learning Spanish, and then 2 years from then you're pretty good at Spanish, and then you go to a Spanish-speaking country, you're able to talk to people, and you feel that self of that feeling of accomplishment. That's a very healthy push for dopamine. Very unhealthy dopamine would be things that take very little effort and give a lot of pleasure. So sugar, Sugar hits the brain and the dopamine centers just as bad as drugs do. Alcohol, nicotine, any drug that causes pleasure. Social media is terrible for dopamine. And most people realize that people will say things on social media they would never say in person. They're kind of different people on there. And I'm not even talking about the negative interactions. I'm talking about the positive interactions where, so for example, in one social media, someone might say, look at my dog, look how cute my dog is. And then 80 people like their comment, and they don't really want a conversation. They just want those likes. That's their drug. And then another person goes, wow, cute dog. I have the same dog. They don't want to talk about their dogs. They just want that original person to like them. And that's really why people get so disgruntled on social media, because they go there for their fix. And then they go, look at my cute dog. And somebody goes, well, your dog's ugly. And then they freak out, even though they should, in real life, if a stranger told them their dog was ugly, they would never care. But on social media, they went for their drug and they didn't get it. And then they get disgruntled. So social media, nicotine, any drug, alcohol, sugar, all of these things that are instant gratification are terrible for the dopamine system. And the worse your dopamine, the worse your testosterone. Let me just check something. Okay, so we have a little bit of time. This is in conclusion, but we can talk a little bit more about the neurotransmitters. So dopamine is one of them. GABA is another calming one. Glutamate is good for memory, but typically it's called, it's people wave their finger at it, and usually they're saying, glutamate's bad for you. It is excitatory, and it can cause cells to die if it gets too ramped up. But the best way to help with glutamate is to help GABA. And one way that we talked about it is pregnenolone, although I wouldn't suggest taking hormones without being assessed first. Serotonin is another big one. Serotonin is essentially your feeling of well-being. People know what low serotonin feels like. That's the anxiety, depression kind of stuff. Weirdly, when you have too high of serotonin, people get road rage. So that's one of the only things that multiple studies have found, that people with too high a serotonin get. So sometimes dopamine and serotonin are on a teeter-totter. So if you know you're a road rage person who otherwise is not anxious or depressed, you probably are high serotonin, possibly low dopamine. And then the reverse, it is possible too. People can be low serotonin, high dopamine. If you're high dopamine, those are the people who are on, who are worriers. And there's typically the people who are getting very quick dopamine hits. So the people who are on social media all day versus super low dopamine, those are called warriors. Essentially they need a lot of dopamine to feel rewarded. And so they're jumping out of airplanes. So you have the warriors who are low dopamine, the high dopamine people who are the warriors. These people take risks to feel rewarded. These people don't. Both are not ideal. Somewhere in the middle is perfect. Let me see. We have a couple minutes left. Does anyone have any questions? I can take questions at this point if you guys want. All right, can anyone hear me?
Yes, I hear you just fine.
Oh, great, perfect. Okay, great.
We can put a copy of the presentation in the chat.
Okay, great.
And if anybody would like it emailed to them who is calling in, email us at mwrbattlecreek@dla.mil, and we'll get that out to you.
One person asked, any suggestions diet, etc., for low side of thyroid. The first thing is, regardless of whether it's primary or autoimmune, I hate to hate on gluten. Gluten is a problem for people with autoimmunity commonly, but there are people who have no problem with gluten. So I don't want to give the impression that everybody in the world should stop gluten. But first, because most thyroid in the United States is autoimmune, cutting gluten will be helpful. Number two, there is research that even non-autoimmune thyroid problems, so if you have primary thyroid and it's not autoimmune, it's still ideal to cut gluten for some reason. So people with thyroid issues, hypothyroidism, even if it's not autoimmune, it's still ideal to cut gluten. I understand why in autoimmunity. There was no explanation in the article for why they think that happens. So the main thing is, you would have to test and be sure. And there's different diets you could do for thyroid, but the main thing is, gluten is ideal to cut. As far as, anything else, exercise is less important for weight loss and more important for hormonal health. And that's really how it aids diet and weight loss. Diet trumps exercise and weight loss. If you eat 2 Oreos, it takes about 10 flights of stairs to burn those 2 Oreos off. And frankly, if you eat only 2 Oreos and then stop, then you're a psychopath. It's either 0 or the whole sleeve. And so, to only eat 2 Oreos and then, you basically cannot exercise off an entire sleeve. 10 flights of stairs for 2 Oreos. So diet is definitely the king of weight loss, but exercise aids in that by creating hormonal health, and the thyroid does benefit from exercise. Now I will say steady state exercise is bad for the thyroid. So that means long distance running for more than 50 minutes. So I'm not saying the people who run 3 miles a day are doing anything wrong, but the people who spend an hour or more running every single day. So I've had ultra marathoners come in and they look healthy and they're extremely skinny and everything. And then their blood work reads like they're a type 2 diabetic, and their cholesterol's through the roof and it looks horrible. And that is all from what's called overtraining syndrome. And that's their thyroid is not functioning well and their cortisol is really not functioning well. HIIT training is better. Walking is fine. It's steady state, but it's not putting an undue stress in the system. So walking is great. Walking is the best exercise there is for health, for regular health. If you're not trying to be an athlete, if you don't have a specific sports goal, walking is the best for health. Followed by crawling and hanging from a whatever. This is great for the spine. Crawling is great for the spine with your head up because it induces posture. But HIIT training is better. Weight training is very good. Weight training is great for weight loss because you increase muscle, which is associated with longer life and stronger bones and everything. But then because you have more muscle, essentially it costs more for you to exist. So you're going to burn more just from living when you have more tissue. Do insurance companies pay for these tests? Depends on the provider. So if your provider's in network and willing to order the tests, then typically they will. It's just a matter of getting them. Sometimes, so when people work with me, do insurance companies pay for the tests? Not for the most part, no. And I just say that so that there's no I just say that because so there's no like hard, like I'll under promise and over deliver kind of thing. Most of the time they won't, because most insurance companies will not cover blood work ordered by a physician who's out of network. So we typically do cash through a co-op that makes it much less expensive. And so that's kind of how we do that. Sometimes the person's insurance will cover out of network physicians. And in that case, let's just make sure that your deductible is met so that you're not hit with a surprise cost and then go with whatever's cheaper. Do you know anyone who treats primary ovarian insufficiency or failure? So that disease process is kind of it's a tough one because it's basically a blanket diagnosis. They're not telling you why there was insufficiency or failure. They're just saying that there is that. And so it kind of depends on where that's coming from. Depends on the cause. So, you know, I have a patient with that and we're helping, but it's a little too early to see how well it's doing. I wish I could give you a better answer for that one. And she has a few other problems that are being helped too. So, and she knows that we're iffy on that, but we're going to do well on the other ones. Can you do flex accounts? Yeah, we can do HSA and flex spending accounts for everything. So any flex or HSA or FSA account we can do. Yeah, so idiopathic means they don't know. Idiopathic means it's caused by something and we have no clue what it is. Suggestions for PCOS. The first thing is lower your carb intake. There's a few other things that you could do. Not, you'd have to do it for to get a, to do blood work on a person and figure out all the problems and then fix all the problems at once, and then also get on a specific diet that could be faster, is just cutting the carbs down going to eventually fix the PCOS? For some people, yes. Some people, you might need a little extra stuff. Also, the keto diet, I like keto diet for weight loss and for type 2 diabetes. I'll use it in PCOS, but you also need to be kind of juggling it with other diets. So you kind of need a little bit of both, because PCOS or a keto diet, sometimes the patient's body can feel like, especially if they're reactive hypoglycemic. So if they wake up at 3 a.m. or if they have trouble in between meals, 6 hours without eating, then sometimes the keto diet can make them pretty not feel good. And then their body feels like they're in an inflamed state. Yeah, if you want to email me, totally, you can. Suggestions for hormonal ants. Is that what is that? Oh, okay. Depends on what time of so if it gets worse around your period, then that's probably an estrogen dominance problem. If not, it kind of depends on your age. So if you're 20s, 30s, it's probably still an estrogen problem. But LSC 3194, yep, you can email me right there. That's totally fine. And that email is actually HIPAA compliant, so you can ask me a health question on there. Now, if I can answer it or not, I might have to have you sign like a consent form or something to be able to answer the question. But how are hormones associated with diagnosed high cholesterol issues? So cholesterol is high when there's a lot of inflammation. They've already proven a few times that paradoxically, high cholesterol foods sometimes do not raise cholesterol in serum. It's really weird. So shrimp is a high cholesterol food and it does not raise LDL. Eggs are a high cholesterol food and most research shows that it does not raise bad cholesterol. And a couple did, but the preponderance of evidence, the strength of the evidence is for eggs. So for the most part, cholesterol comes from inflammation, and inflammation does harm the hormonal system. But does having this hormone, get worse or better with high cholesterol, or does it cause higher or low cholesterol? Not really so much directly, so much as when the immune system's bad, they're both bad. On the other hand, people who restrict cholesterol like shrimp, or like good cholesterol like shrimp and eggs, sometimes can not have enough building blocks, since we know that cholesterol is the building block for steroids, for hormones, I mean by that. Since we know that cholesterol is the building blocks for those, if you're not taking enough in, that can be problematic eventually. But that takes years and years to happen. Are they are associated, but they aren't directly linked, if that makes sense. So I had a patient who on his food panel, he went to a natural person and the natural person said, you should eat one of every nut every single day. And that's like nature's perfect multivitamin, even though nuts are seasonal. So there's no way that humans before cities could have accessed nuts every single day, especially not every species of nut every single day. That's impossible. But he said that. And so the guy was doing his program and didn't get any better. And so he came to see me. And he did a food sensitivity panel and a real one, one that's actually through a good lab. And what we found was he was sensitive to every single nut, but he was not sensitive to cheese or eggs. And so we put him on the diet based on his blood work, based on what the panel said. And he was worried that his cholesterol would go up because he started eating more cheese and more eggs and less nuts. And the opposite happened. His cholesterol came down. Why is that? Because he's cutting his inflammation and he's only eating foods that don't inflame him. We know that cheese doesn't inflame him because the test said so. Cheese gets a bad name. It's because it can be inflammatory for people. It's common for it to be inflammatory for people. But it's not guaranteed, just like gluten, it's not guaranteed to be inflammatory for every single person. So you got people out here like, well, humans shouldn't eat the milk from another animal. It's like, well, humans have brains. And sometimes humans just need to get their nutrients from whatever they can get it from because we're opportunistic. And so we're allowed to use our brains, that's natural. We're allowed to invent things. We're allowed to do, use technology. And there's just a balance. So that was kind of a funny situation where the cheese actually lowered the cholesterol. And it just goes to show you, we shouldn't wave our fingers and say, like paleo diet, oh, well, grains, beans, and dairy are always bad for you. Well, most people don't get enough good fats and good protein. And so if you're not sensitive to cheese, then you should eat it because it's a common way to get, vitamin A, vitamin D, vitamin K2, all these fat soluble vitamins and good healthy fat and good protein. As long as you're not sensitive to it, then eat it. If you are sensitive to it, then don't eat it. It's that easy. If you're wondering if you're sensitive to something, stop eating it for 30 days and then eat a ton of it for 2 days. And if you flare, then you know you're sensitive to it. You sometimes won't know you're sensitive to something until you've cut it for 30 days. So if you eat something, a couple of days a week or every day, you're not going to feel very bad when you eat it. Cut it for 30 days, eat it, see if you get so we did food sensitivity testing. And so we do that. So there's 2 types of food sensitivity testing. If you go on Google, half the people are going to say food sensitivity testing is good and half of them are going to say it's bad. The truth is half of it is bad and half of it's good. So bad testing would be some people call it cell shrinkage or cell swelling testing. That's basically where they put a particle of food on a blood cell and they look at it under a microscope and they see how much it swells. It's very unscientific. It's 68% variable. So that was in a research study. They took blood from a person, then they took instantly blood from the same arm of that same person. They did this for a few different people, 6 people, I think. And then they sent both blood samples to the cell swelling lab with different names on it, even though they're the same person. And they got different results, up to 68% variable. So those are garbage tests. And some of those companies you need to watch out for because they're very confident that they're right and they are very persuasive, but they are garbage testing. There's good food sensitivity testing too. That's based on antibodies. So IgG, IgA, and sometimes IgM antibodies. That is real testing. It's only 1% variable. So is it perfect? There can be false positives, false negatives. I think there's a 7%, there's a 1% variability. So 1%, it could change. But 1% is really good. In medical testing, 9% is what the kind of cutoff point is. So your medical test needs to be 9% accurate. Or 80 or 91% accurate. So only a 9% variability for it to be acceptable. And IgG testing is better than that. So yep, I do food sensitivity testing, not on every patient. Sometimes patients so sick that we shouldn't do that at first because we need to heal things up or else it's going to look terrible. Sometimes money is an issue, so we don't do it. A lot of times it's just better to do diet first, heal the body a little bit, and then get a look at what's still kind of holding on.
Can you provide your address for your practice or office?
Sure, I'll type it in.
Actually, I can't see the screen. I'm just on the phone.
Oh, sure. It's 5228 Lovers Lane, and that's Suite 110 in Portage, Michigan, 49002. I'll put that in the chat also.
Thank
you think? Yeah, absolutely. Do you think a major surgery could be enough to throw the system off? Depends on the surgery, and it depends on what part of the system. So like if we're talking about the hormonal system, kind of depends on the surgery. You know, a brain surgery, somebody gets a tumor removed successfully, that could definitely do it. Yeah, hysterectomy could do it. Sometimes that makes people feel better, and sometimes they need some help as far as, you know, sometimes getting a hysterectomy can feel a lot like menopause as far as having less estrogen action. So yeah, that can do it. Some people get them and they feel like a new woman. Some people not so much. So sometimes they're a great idea. Sometimes they're the necessary idea, but then you need to do work after to kind of make the person feel comfortable again. And you know, nobody does those surgeries lightly, so you know they're obviously always necessary. It's just a matter of, you know, how people feel after, and doesn't mean that it was wrong to do, even feel worse after. It's just we need to do things to get the system right and get the system oriented with what it's got now. Cool. Any other questions? I could probably do two or three more.
Martha, will you send out his point of contact information to those of us that request it?
Sure will do.
Thank you.
Yeah, anyone who's on their phone, the email I have up on the screen is info@prosperhealthclinics.com. So info@prosperhealthclinics with an S.com. And I have to travel this week, so probably if you email me, I'll get to you sometime next week. So cool.
Thank
That
you.
was fun.
Thank you very much, Dr. Ball. I really appreciate you staying a little bit longer to answer our questions, and hope to have you some other time for another Lunch and Learn.
Awesome. Yeah, I'd love to be back.